Thank you very much. It's great to be here. So the title is a little strange and provocative, and I think that Jagat chose it because we published this paper in JACC several years ago that says leukocytes link local and systemic inflammation in ischemic cardiovascular disease and expanded cardiovascular continuum. And I hope by the end of the talk I will have sewn this together. And there's another reason I think you chose this topic, and that's because Mount Sinai just recruited to be the head of a cardiovascular research institute the senior author of this paper, Philip Swirsky, who was my trainee but soon became my teacher. And isn't that the greatest thing that can happen to you, is when your students become your teachers? So congratulations to this institution for a brilliant recruitment, because Philip is blazingly creative and is going to really do wonderful things here. These are my competing interests. I do not accept any personal payment from any pharma or device company. So why should we talk about inflammation and leukocytes at a meeting that really is focused on clinical care? It's because these concepts that we're going to be dealing with and that were introduced by Dr. Fuster really do have important clinical consequences to understanding the disease that preoccupies us in our clinical daily practice. And the fundamental issue that I'm going to be discussing, or I was asked to discuss here, is there clinically important crosstalk between foci of inflammation in cardiovascular pathogenesis? Now, the initial hypothesis, which germinated in my laboratory actually in the 1980s, was that systemic inflammation can elicit an echo in the prepared soil of the arterial wall that is beginning to have this subclinical atherosclerosis early in life, and that can aggravate atherosclerosis. So you see these publications from work that was done in the 1980s, begun in the 1980s. You'll notice that no one in cardiology was interested in inflammation at the time, so I had to publish in pathology literature and in the nutrition literature. And the bottom line of these early studies, before we had mutant mice that developed atherosclerosis, we did these in rabbits, focus in panel A on the right-hand pair of images that are blank when we probed for interleukin-1 alpha, a pro-inflammatory cytokine, or interleukin-1 beta, using a northern blot, which is a antediluvian technique that we do not use anymore. And you'll see that whether or not we had created atherosclerosis in these rabbits or not, when we extracted the arterial RNA, we saw no signal for expression of these pro-inflammatory cytokines. But let's move over to the left-hand blots. And we factored in here not only atherosclerosis, but a systemic inflammatory stimulus. We mimicked septic shock by giving an intravenous injection of bacterial endotoxin, lipopolysaccharide. And you can see that if you give the exogenous stimulus, say mimicking septic shock that we see in our patients all too often, you do elicit some expression of these pro-inflammatory genes in arterial extracts. But when we have a pre-existing atherosclerotic lesion, look what happens. It's like a nuclear explosion with very elevated RNA expression for the inflammatory mediators. Now, we did a second study where we created graded degrees of atherosclerosis by dietary cholesterol manipulation. And as we got more and more lesion due to increased consumption of cholesterol by these bunnies, we were able to elicit a bigger bang by giving the exogenous pro-inflammatory stimulus, the bacterial endotoxin. So this was really germinating the idea that there was crosstalk between systemic inflammation and local inflammation in the artery. Now, this concept has been really elaborated with recent work from Eike Latz and from Minahe Netea, who is a pioneer in trained immunity. And the concept here, you've already heard about the NLRP3 inflammasome from Valentin. The concept is that, yes, you activate inflammation with an unhealthy diet. But what Netea and Latz were able to contribute is that primes you for a bigger response the next time. Okay? This is probably due to epigenetic changes or reprogramming of your responsiveness to inflammatory stimuli. Keep your eye on this concept, because as we unravel it, it's going to be very important for understanding what happens in our patients. So a follow-on hypothesis was posed by Philip Swirsky and Matthias Narendorf that one of the remote stimuli for boosting atherosclerosis could be myocardial infarction itself, which is a very hot nidus of inflammation. And so the hypothesis was that you can get an echo in the arterial wall of inflammation due to acute myocardial infarction, and that will aggravate atherosclerosis. This study was magnificent and carried out by Partha Dutta, who was a postdoctoral fellow in the group of Phil and Matthias, and he's now doing very well as a faculty member in Pittsburgh. And what he did was to ligate a coronary artery in a mouse and then image for protease activity. Now, my laboratory and others had shown, we showed it in vascular cells and in macrophages, that these proteases are induced by pro-inflammatory mediators such as interleukin-1. And we use this as an index of molecular imaging for inflammation. And what we found, if you look in the left-hand series of images, was that as late as 3 weeks after ligating the coronary artery, when the inflammation in the myocardium from the infarct is beginning to subside, that we still had imaging signal for inflammation as gauged by protease activity. And that's shown in the graph that's in the middle of this slide. Now, was that coming from the heart or the aorta? It's a little fuzzy, isn't it, in this CT fluorescence tomography kind of study in vivo. So you can dissect out the aorta and do epifluorescent measurements, and you can see that the inflammation was not in the infarct, it was in the artery. So we did see an echo of inflammation caused by the infarct in the artery. Now, the second project that Dr. Swirsky did in our group was to define a subset of pro-inflammatory monocytes that are elicited by a hypercholesterolemic diet and which characterize the atherosclerotic population of mononuclear phagocytes. And what Partha found was that after ligation of a coronary artery, experimental myocardial infarction in mice, that this pro-inflammatory subset of leukocytes that we mark by having high levels of LY6C, that they accumulated much more than in animals who consumed a high cholesterol diet but did not have a myocardial infarction. I'm going to quickly go through some brilliant detective work that was led by Phil and Matthias, that the pro-inflammatory monocytes that show up in the myocardium a few hours after coronary ligation, they actually come in the mouse from a preformed pool of pro-inflammatory monocytes ready for emergency mobilization that live in the spleen. That was in this science paper. And where do those splenic cells come from? They come from the bone marrow, as Dr. Fuster was teaching us. Now, looking at proliferation of cells in the bone marrow, reflecting hematopoiesis, you can see that after ligation of a coronary artery, in the left-hand graph, there's an increase in hematopoietic stem cells about 3 days after ligating a coronary artery. So we have now the infarct is talking to the bone marrow. And you can do this imaging study using an analog of thymidine and show that actually the bone marrow is lighting up. You see those vertebral bodies are hot, as shown by the yellow and orange colors there in the MI image, and is quantitated in the bar graph to the right of this slide. So, who cares about what mice do when you tie off a coronary artery? We're concerned with our patients. And do any of these concepts apply to humans? And indeed, they do. And Mount Sinai has been pioneering with Zaid Fayyad and collaborations with the group at the Mass General in this area. And what you can see here is co-localization of glucose uptake, which is an index of inflammation, or at least accumulation of inflammatory cells in, say, panel B, and this marker of cell proliferation, the thymidine analog in panel C. So yeah, it looks like lesions in humans are also inflamed and there's proliferation. But now let's see if that cardiosplenic axis that was delineated in the mouse applies to humans. And this is work to which Ahmed Tawakkol contributed, as well as Matthias and Phil, that shows that after myocardial infarction, acute coronary syndrome in the upper series of images, that there is not only increased uptake of fluorodeoxyglucose in the atheroma, the aortic atheroma as you see there, but also in the bone marrow compared to normal in the middle image on the bottom, and also in the spleen. Okay? So this cardiosplenic axis indeed operates in humans following myocardial infarction. Now let's take this to the bedside. The observational epidemiology is very clear in patients who have had an acute coronary syndrome that the in-hospital mortality correlates with the degree of leukocytosis. You see, there are many studies. This is just one, and it shows that if you have very high leukocyte, very low leukocyte count, if you can't mount a leukocytosis, you're in trouble as well. But we know that from common clinical experience. And here we're not looking at infarct patients, we're just looking at two separate cohorts that show that your ambient leukocyte count actually counts in terms of cardiovascular short-term and long-term mortality. Now, one of my predecessors as the chief of cardiology at Brigham and Women's was the great Sam Levine, one of the founders of our specialty in the early part of the last century. And in 1929, he made the following statement. Now, I want to pause for a moment because there may be residents and fellows listening. Dr. Levine didn't have a cell sorter. He didn't have a PCR machine, but he had keen powers of observation, and he let the patient be his teacher. And in 1929, with a hemocytometer and a thermometer, he made the following statement. The extent of fever and leukocytosis probably depends on the amount of infarcted cardiac tissue involved. Infarcted tissue probably liberates toxic products that produce leukocytosis and fever. The leukocyte count is apt to run hand in hand with the fever. The presence of a leukocytosis is one of the most constant findings in coronary thrombosis. 1929, okay? What prescience and what a paean to careful clinical observation and correlation of laboratory studies with the clinical picture. So let's now go to the 21st century with this concept. What mediates fever? Interleukin-1 is the endogenous pyrogen. My buddy, Charles DiNarello, purified interleukin-1, kitty corner from my first laboratory in the early 1980s, on the basis of its ability to raise temperature, rectal temperature in rabbits. Can you imagine young people doing a screen of a column by a bioassay that involved taking rectal temperature of a bunch of rabbits lined up? But that's how Charles was able to identify the elusive endogenous pyrogen as interleukin-1. So I was involved in instigating and conducting with Paul Ritker, my clinical partner, a study that neutralized interleukin-1 beta in patients. It's another story, and you've heard it from Dr. Ritker, I'm sure. The first study that actually showed that targeting inflammation can benefit patients with coronary disease. But we had a tool antibody. This was similar to canakinumab, which was the clinical antibody that we used in the CANTOS trial. And I got together with Phil and Matthias and a brilliant postdoc, Hendrik Seger, and we actually targeted interleukin-1 beta with an antibody in mice with coronary ligation. Now, I ignored the cloud on the left there. That's cell sorting, and that's Philip Swirsky is a maestro of cell sorting, but just look at the graphs there, which give you the bottom line of the cell sorting experiment, is that after infarct, if you give an anti-inflammatory antibody that blocks this endogenous pyrogen, IL-1 beta, that you decrease neutrophils, macrophages, and guess what? You mute those pesky pro-inflammatory monocytes that Phil characterized, but not the reparative, less inflammatory subset. And if you look in the tissue after infarct, you actually see in the right-hand series of images that the anti-IL-1 beta therapy reduces the leukocytes marked by CD11b or granulocytes that bear Ly6G. So neutrophils and leukocytes decrease. And what is clinically important is that if you follow up a month later, that you have less of a decrement in left ventricular dysfunction, as shown by 7 Tesla MR in these little itty-bitty mice. Okay? You see in the bottom panel on the right, the decrease in ejection fraction is less if you treat with an antibody. Now, we struggled mightily to get Novartis to do CANTOS 2, which was to take this concept to patients, but we showed them in the CANTOS trial that IL-1 beta neutralization had an anti-cancer effect, and so Novartis is often running in the cancer field with this antibody, and we will not have it for cardiac practice. But I'm not going to go through this, but if you actually read the paper, it's got a lot of sophisticated biological experiments, including parabiosis experiments, that suggest that the effect of neutralizing IL-1 beta is both local and at the level of the bone marrow. So I subtitled that article in JACC, The Cardiovascular Continuum Revisited. And that was in homage to my mentor, Dr. Eugene Braunwald, now 92 years old. We were connected yesterday. I spent an hour and a half at his feet last Friday. We're constantly working together, and I never leave his presence without having learned something. And he and Victor Zell, my contemporary, devised the cardiovascular continuum. This old black and white image is from 30 years ago, okay? Showing the cycle from risk factors, which we heard about from Valentine, through what we call today advanced heart disease. But what I played out with you here this morning is that we can amplify that cardiovascular continuum to really encompass hematopoiesis in the bone marrow, extramedullary hematopoiesis and mobilization of cells in the spleen, the nervous system. Dr. Fuster had an image with the brain cut, and indeed, sympathetic signals can turn on hematopoiesis, and we're able to really enlarge this circle and have a more global view that synthesizes neurology, hematology, and cardiology all in one beautiful biological basket. Now, this concept of stress and effects on the atheroma has been very recently expanded by Hendrik, who did that IL-1 beta neutralization study when he was a fellow. Now he's at Thun, the Technische Universität München in Germany, and he continued this work, and we were fortunate to be able to collaborate with him, showing that acute mental stress in mice can promote plaque destabilization in atherosclerosis in mice. So again, the brain, the sympathetic nervous system, and the athero connection expands, and its biological basis becomes surer and stronger every year with advanced studies. Now, that kind of picture actually resembles this one, doesn't it? And this brings it home clinically because we all see patients with stress cardiomyopathy, Takotsubo. If this were my diagram, we'd actually see apical ballooning in the bottom image. Okay, we'll have to give him a pass on that. But the point is that this not only affects the atheroma, but also the myocardium, this axis from brain, sympathetic nervous system, and inflammation. I'm going to close, as we started today, with taking this concept home for clinically important crosstalk between systemic and local inflammation in COVID-19. So Valentine was good enough to show a figure from this review. I want to point out that this is the culmination of many meetings that we had. We call them 3I meetings for inflammation, immunity, and infection. And this was published in 2018 before we had dreamt of SARS-CoV-2. And the point that I made here is that when you have remote sites of inflammation, see the joint with arthritis, or infection, okay, that you can evoke that echo that we modeled with those rabbit experiments back in the 1980s, and that could actually affect the prepared soil of the atheroma and prompt a type 1 myocardial infarction. And it is not by chance that we specifically invoked viral pneumonitis as one of the triggers for this echo phenomenon. When we have a patient who's very ill with COVID, as we heard about in the first talk this morning, it's a perfect storm for a type 2 myocardial infarction, isn't it? Tachycardia and fever, increased oxygen demand, hypotension and hypoxemia reduce oxygen delivery, setting the stage for myocardial ischemia. So we have this demand-supply imbalance. We have the accelerated atherosclerosis due to the echo. We have a thrombotic diathesis, which I don't have time to go into, but you heard a bit about earlier. And then the vascular dysfunction with vasoplegia because of impaired endothelial-dependent vasodilatation. So it's a perfect storm. Now, how do we bring it home to inflammation in the cardiovascular system? This is a paper which will appear in the American Journal of Pathology. See, I still publish in pathology journals in January, and this just went online a few days ago. And we studied a small number of autopsy patients who were very well studied at the Brigham, and we collaborated with our colleagues at Yale who had advanced microscopy. And what we were able to show here is that we didn't, as we were discussing at dinner last night, see evidence for direct viral infection of the cardiac myocytes causing myocarditis. We also didn't see a lot of lymphocytic infiltrates that would indicate myocarditis, but boy, did we see mischief in the vessels. The big vessels, the big arteries, the tiny arteries had thrombi. And when we looked for what was the evildoer there, we found it was actually the granulocyte. We found that there were neutrophil platelet complexes caked in these affected micro and macro vessels, and we found that there was activation of neutrophil extracellular traps. These are structures that I could give a whole talk about that are at the cutting edge of thrombosis these days. And so we think that the neutrophil becomes activated in COVID-19 and actually can cause damage to the myocardium by local thrombosis and propagation. So this is what I was able to do with your title that you gave me, to try to weave together the local and the global. And I tried to make sure that some of the basic science experiments that we conducted were really brought home to clinically important problems that you struggle with and I struggle with in our daily clinical practice. And of course, one of the great things about our enterprise is the ability to work with colleagues who are smarter and more talented than yourself. And here's a list of my collaborators. Thank you so much.